low socioeconomic status contributes to heart disease. While heart disease affects people of all socioeconomic statuses, poverty is directly related to increased risk factors. A lack of resources makes it harder for those in poverty to get needed medical care, and low socioeconomic status is directly related to poor lifestyle habits and behaviors. Overall, the U.S. spent more than $500 billion in 2010 on health problems related to heart disease and stroke. Heart disease is the leading cause of death in the United States. Preventable or controllable conditions that cause heart disease are high blood pressure, high cholesterol, cigarette smoking, diabetes, poor diet and physical activity, and being overweight or obese. Disparities within the population affect access to treatment, increased risk factors, medical treatment, treatment outcomes, and mortality. Poor minorities receive worse care than the higher income majority white population. Assessment is important in the field of public health because it addresses the nature of issues that affect public health. It is used to diagnose, investigate, and monitor health disparities, conditions, and illnesses in order to maintain the general welfare of the population. In order to understand the nature of disease, whether it has a chronic or infectious nature, the assessment phase is vital to implementing public health strategies in order to correct or improve the situation. It is important to analyze the psychological and physical health risks present in exposure to poverty over long periods of time. Living in impoverished conditions increases negative stress within the environment, as compared to the amount of negative stress associated with higher socioeconomic statuses. Stress-related negative factors and environmental conditions are linked to heart disease. Depression, stress, and a history of attempted suicide have also been linked to increased risks for developing heart disease. In adults younger than 40 years, depression and a history of attempted suicide are significant dependent factors when predicting the premature cardiovascular disease and ischemic heart disease mortality in men and women. Economic and social conditions have a larger effect on heart disease than medical treatment and lifestyle choices. Factors that greatly contribute to heart disease are material deprivation, psychosocial stress, and engaging in unhealthy behaviors in order to cope with stress. Poverty increases the risk factors that lead to heart disease due to social exclusion. Social exclusion increases exposure to negative events like hunger, food selection or choices, the quality of food, insufficient housing, inadequate clothing, and poor conditions surrounding the environments people work and live in. Those suffering from social deprivation have less access to positive resources like education, reading material, public events, and leisurely or recreational activities that would reduce stress. Risk factors outlined by epidemiological means are gender, heredity, age, physical inactivity, smoking, obesity, high blood pressure, high cholesterol, and daily nutrition. A lack of resources like access to healthy foods, a conducive environment for physical activity, education, and affordable health care have caused increased risks for cardiovascular health in those who are impoverished. Environmental factors like pollution can decrease the amount of physical activity a person does. Poverty can lead to a lack of quality food through food deserts due to physical location. A lack of health education can lead to increased behavioral and social risks for heart disease. An example, smoking, not exercising enough, choosing poor dietary choices, and reduced income. Reduced income places a person at risk for having reduced access to health care and medical treatments. Heart disease and stroke are responsible for nearly a third of all deaths in the United States. Coronary heart disease is responsible for 2/3 of all heart disease-related deaths. More males die of heart disease than females. People ages 74 years and older have the highest reported number of deaths associated with heart disease. White non-Hispanic and black non-Hispanics were the highest ethnicities to be affected. Education level can also be linked to an increased risk to heart disease in a roundabout way. It is widely known that smoking cigarettes can be a cause for heart disease and many other health risks. Over 65% of individuals with a GED or no high school degree or education report to smoking cigarettes, while less than 10% with a bachelor's degree do. This can also be linked to poverty level as well. Americans living under the poverty level are twice as likely to smoke cigarettes than those living over the poverty level. Education is linked to both human and social capital. Human capital is an important determinant when it comes to a person's social and economic status. Higher levels of human capital affect education, income, and the positive aspects of a person's environment. Obtaining a higher education is directly related to social and economic opportunities. These opportunities can come in the form of higher paying employment and obtaining a job with a company or business that offers health insurance and other benefits. Lower education levels are associated with less income and poorer living and working environments. It is important to monitor the health status in order to identify and solve health problems. Conducting studies of the population and correlating them with certain illnesses are only the beginning. Once we have determined that heart disease is linked to low socioeconomic status, we have only identified the issue. Then we must solve the issue by monitoring and educating the public on risk factors. A common method doing this is exemplified in the FDA by monitoring our food supply and making sure it is safe from bioterrorism threats. Although we are at greater risk of heart disease than we are of bioterrorism threats, we do not have to monitor, we do monitor this with the same sort of method. The way we do this is related to heart disease, as amongst the low poverty populations, is by monitoring health and identifying risk factors. Public health can implement corrective actions, policies, and procedures that are designed to reduce the occurrence of chronic diseases. In this case, heart disease. Public health organizations are essential when it comes to identifying and solving health problems. For example, mortality from heart disease and stroke have declined immensely in the last 5 years. Between 1960 and 2009, heart disease mortality declined by 68%. The reason for this decline can be attributed to public health organizations educating the public on effects like smoking, as well as technological improvements in screening for cardiovascular diseases. After determining risk factors, public health organizations like the CDC can track and investigate the issues responsible for increased risk factors. In terms of poverty, public health organizations will look at the disparities that cause risk factors. After identifying the problem and determining potential corrective actions, public health organizations can implement changes that will reduce the disparities associated with increased risks for heart disease. When it comes to the increased risk for developing heart disease, public health entities are actively trying to reduce health disparities within the population. The role of public health in diagnosing and investigating heart disease is much simpler. The research has already been done to prove link between smoking, a lack of exercise, and stress are related to developing heart disease. This issue can always go back on education. Areas of poverty or low socioeconomic status are often uneducated or simply possess a lower education. In educating areas where low socioeconomic status is prevalent, public health organizations may be able to combat the increased risk for heart disease. As stated previously, areas of low socioeconomic status have a higher percentage of drinking and smoking cigarettes. They are also less likely to exercise on a regular basis. Lowering the percentage of cigarette smokers, increasing the education about health risks, and improving diet and exercise in poverty-stricken areas should reduce the amount of people with heart disease in the future. Policy. After assessments are complete, public health organizations and officials can draft policies in order to address health concerns. Policy development is essential when it comes to planning a strategic course of action in order to improve health outcomes of the population. Policies include a basic plan of action, how it will be implemented, and the expected health outcomes. Many health initiatives have been implemented to reduce heart disease, both in the U.S. and internationally. These general policies have been enacted to address the issues of heart disease. Policies like the Victoria Declaration in 1992 and the Catalonia Declaration in 1998 have made efforts to coordinate public health efforts through the government and private sector while assessing what kind of resources and assets would be needed to properly invest in heart health programs. General policies have increased the screening process for early detection by checking things like high blood pressure and high cholesterol. Medical screening processes and public education have improved the detection and recognition of heart disease and stroke. As of 2011, the U.S., Europe, and Canada have been working on a policy toolkit to reduce cardiovascular disease. This partnership between the National Forum for Heart Disease and Stroke Prevention and the Collaborative Integrated Non-Communicable Diseases Intervention Program will use this policy toolkit to increase public awareness while trying to reduce the risk factors associated with developing heart disease. Before policies can be drafted and implemented, the link between poverty and health diseases must be addressed. In the United States, the Behavioral Risk Factor Surveillance Study highlighted the differences in coronary heart disease between states, with most occurring in the lower Mississippi and Ohio River valleys. A California study showed that there were higher death rates caused by heart disease in the poorer Los Angeles County than in the wealthier California counties. The study also concluded that poorer black communities were more likely to die from heart disease than the wealthier communities. This could be linked to a lower access to care, non-existent regular checkups, and delays in treatment. Studies in Brazil and Italy show a correlation between low socioeconomic status and heart disease. The Global Cardiovascular Infobase showed that mortality rates from heart disease are increased in the percentage of the population living below the poverty line. There is a much higher death rate associated with countries that have a higher percentage of the population living below the poverty line. Individuals in Canada living under poverty are exposed to a lack of food quality, poor housing quality, inadequate clothing, and poor environmental conditions. Because of this, poverty is arguably a greater predictor of heart disease than risk factors such as smoking, obesity, stress, or blood cholesterol concentrations. As poverty affects the overall environment that leads to increased risk factors, the remedy to this is to increase welfare and unemployment, improve the pay equality, establish a national guaranteed minimum income, increase taxes on the wealthy, and establish a national daycare or pharmacare. In order to address heart disease on a demographic level, several policies have been implemented to reduce heart disease in low socioeconomic populations. The Affordable Care Act, or ACA, has been implemented to address the fundamental lack of insurance in the United States. It works through establishing health care exchanges in every state. These healthcare marketplaces offer different healthcare plans to fit the needs of customers. With millions of people who previously couldn't afford health insurance becoming insured, more people will have access to health care. This will address key prevention strategies to reduce chronic and infectious diseases from the populations. Other government policies in the U.S. have addressed some of these risk factors by implementing nutritional assistance programs, unemployment programs, welfare, and medical access. Existing policies have brought awareness to heart disease and are actively encouraging changes that are designed to reduce risk factors. Some of these existing policies, reducing the amount of trans fats in food, label food products to warn about sodium, trans fats, and saturated fat content, and establish activity guidelines. Lawmakers passed a smoke-free workplace legislation, which covers 55% of the United States. The policy went into effect in May of 2007. The Tobacco Products Regulation 21 CFR was enacted to establish restrictions on the sale, distribution, and use of cigarettes and smokeless tobacco in order to reduce the number of children and adolescents who use these products, and to reduce life-threatening consequences associated with tobacco use. Tobacco products are used more frequently in areas of low socioeconomic status. This law is an attempt to lower the exposure to tobacco amongst youth and hopefully decrease the percentage of children and adolescents who use tobacco products. Arnold